activity. And live classes are basically to elevate the learning of all the first year students. Then also on Auricle, we provide recorded session in which all the student of first year will have the access of all the subjects anywhere, anytime to the recorded sessions. And also on Auricle, we provide the ultimate comprehensive book with CBME based question answers, MCQ. Then MCQs are also there that are from beginner level to expert level, which contain standard multiple choice questions. Then student can also book a slot for personalized counseling session in which there will be a direct interaction of the student with the counselor. Then some subscription plans are there, starting from basic to premium. So basic plan is of 3 months, standard plan is of 6 months, and premium plan is of 12 months. And the cost of the premium plan is around 50,000. The services included like pre-recorded class, live doubt clarification, one-to-one personalized guidance, notes, quick revision, examination module. And also for 20% instant discount, you can use my code, that is Anchal20. So as we have started the series, so these are the various sessions that are going to occur in the month of April. So before proceeding, let's start with a clinical case scenario that is of a 45-year-old male that present to emergency department with complaint of yellowing of the skin. So yellowing of the skin is directly indicating that the person is suffering from the jaundice, of the condition of jaundice, because yellowishness is the first symptom of the jaundice. So yellowish of the skin and eyes along with dark urine, mild abdominal discomfort. Upon examination, notice jaundice, scleral icterus, and mild hepatomegaly. Laboratory tests reveal elevated level of total bilirubin and direct bilirubin. What is the likely mechanism behind the dark urine observed in this patient? So we have some options, like first we have accumulation of urobilinogen in the urine. Second, the presence of conjugated bilirubin in the urine. Then hematuria due to liver dysfunction, and the last we have renal tubular damage. So this we're going to discuss in the end of the session. So let's proceed with today's topic, that is jaundice. So jaundice is basically the yellowish discoloration of the skin, in which the patient will show the first symptom that will be the skin will become yellowish. And yellowish discoloration of skin along with sclera and mucous membrane as a result of hyperbilirubinemia means there will be elevated level of bilirubin in blood. Right? So that is known as hyperbilirubinemia. Okay, now what is the normal range of bilirubin that there inside blood? So it will be normal serum level of bilirubin is 0.2 to 0.8 mg per deciliter. And whenever the serum level of bilirubin get exceed above this level, so there will be starting of the this condition that is known as jaundice, and it confirm whenever it exceeds above 2 mg per deciliter. Okay, so whenever bilirubin is more than 2 mg per deciliter, for jaundice to be visible on examination, and the first symptom that will appear, that will be yellowish discoloration of skin, sclera, and mucous membrane. And the first thing that will become jaundice in that those patient will be posterior sclera. This is the first symptom that will be shown by the patient that is suffering from this disorder. Okay, now as we can see in the picture also, the person with normal skin color and the person who is having jaundice. So the skin become yellowish, as you can see in the picture. Yellowing is associated with the accumulation of bilirubin in the skin, most often caused by liver and gallbladder disorders. So what are those disorders? How gallbladder and liver is involved in this, that we're going to learn in today's session. So now we're going to discuss what are the causes that are responsible for jaundice, right? So whenever there is too much bilirubin being produced from the liver and unable to remove from the blood, for example, patient with hemolytic anemia. Hemolytic anemia is that anemia in which there will be excess destruction of red blood cells, right? Have an abnormally rapid rate of destruction of their blood cells that release large amount of bilirubin into the blood. Okay, so this is the cause of the pre-hepatic jaundice, in which there will be excess unconjugated bilirubin will get accumulated due to excessive destruction of the RBC, right? Then second cause, we have a defect in the liver that prevent bilirubin from being removed from the blood, converted to bilirubin gluconoric acid that is conjugated or secreted in bile. So this is the second case. And third, there will be blockage of the bile duct that decrease the flow of bile and bilirubin from the liver into the intestine. For example, the bile duct be blocked by cancer or due to presence of any gallstone or due to inflammation of bile duct. The decreased conjugation, secretion or flow of bile that can result in jaundice is refers to as cholestasis. However, cholestasis does not always in jaundice. Okay, so the third case that we have discussed is the cause of post-hepatic jaundice. The first was the cause of pre-hepatic jaundice. And the second that we have discussed, that was the cause of hepatic jaundice. Now, one by one, we're going to learn that how all these causes are occurring, and all this we're going to learn with the help of fate of bilirubin. Right? So, what happened whenever the lifespan of RBC get completed, right? If this is the RBC, red blood cell, so whenever the lifespan of RBC get completed after 120 days, so the membrane of this RBC will become fragile and it will get ruptured and there will be ejection of hemoglobin, right? From this hemoglobin, there will be formation of bilirubin. And how this will occur, that also we're going to learn in fate of hemoglobin. Okay, so from this hemoglobin, there will be formation of bilirubin. Okay, now what will happen? This bilirubin on reaching the liver, right now this is unconjugated, right? Unconjugated, which is water insoluble. Okay, so this bilirubin on reaching the liver, this free unconjugated bilirubin is split from albumin and enters into the hepatic cell. Okay, the cells present inside liver is hepatic cell. Okay, so whenever this free unconjugated bilirubin reaches the liver, so this gets split from albumin and enters the hepatic cells, and in hepatic cells it undergoes conjugation with UDPGA. Please remember UDPGA. So whenever this unconjugated bilirubin enters inside the hepatic cells, it undergoes conjugation with UDPGA. UDPGA is uridine diphosphate gluconoric acid, right? So in a reaction catalyzed by enzyme, and the name of the enzyme is gluconide transferase. This is the name of the enzyme, right? So in a reaction catalyzed by gluconide transferase to form the bilirubin mono and digluconides, right? Now, from here, after entering into the liver, this unconjugated bilirubin get converted into conjugated bilirubin. Okay, means it will become water soluble now, right? Now, what will happen after this? Now, there will be excretion of this conjugated bilirubin by hepatic cells along into the bile caniculi. Okay, so there will be excretion will occur with the help of bile caniculi, and here we have drawn the intestine. Okay, so this is small intestine. This we have common bile duct. Now, what will happen? Whenever there will be excretion of conjugated bilirubin by the hepatic cells into this bile duct, right? And it is an active process. Whenever there will be transport, again a concentration gradient into the bile caniculi, and this is the rate limiting step in the liver for handling of bilirubin, and also it needs energy for this process. Now, some of it escape into the general circulation and also excreted by kidney. Okay, some of this conjugated bilirubin get escapes into the circulation and also excreted by kidney in urine, as if this is kidney. Okay, so some will be excreted by kidney as urine urobilinogen, right? And also some will be excreted with feces as stercobilinogen. Okay, so this is the all step. Now, when this conjugated water-soluble bilirubin reaches the large intestine, okay, this is the intestine we have drawn, reaches the large intestine, it is degraded by colonic bacteria present in the large intestine, and here it will form a compound that is known as stercobilinogen, which get excreted with feces. Okay, so this is all about the general physiology, the general fate of bilirubin, to have the idea that what is going on with the bilirubin. Okay, now we have seen that before entering into the liver, this bilirubin was unconjugated, and after entering into the liver, that bilirubin get conjugated, right? So what is the site of conjugation? That is liver. Okay, and here we have a bile duct from where the bilirubin get entered into the intestine, right? Now, one by one, we're going to learn that what are the different types of jaundice and what are the causes that are responsible for this condition. Okay, so first we're going to learn prehepatic jaundice or hemolytic. So as the name suggests, prehepatic. Prehepatic means before liver, the bilirubin before entering into the liver. Or hemolytic means whenever there is excessive destruction of RBC. So as the name suggests, prehepatic means whenever the bilirubin has not entered into the liver, and hemolytic means whenever excessive destruction of RBC is there. Okay, so it is a type of jaundice that occurs because of excessive destruction of RBC, right? So if there will be excessive destruction of RBC, so there will be increased blood level of unconjugated bilirubin, right? And in this condition, the excretory function of liver will be normal. So all the liver function will be normal. Okay, now, but the quantity of bilirubin increase anonymously, and the liver cells cannot excrete that much excess bilirubin rapidly, and unconjugated bilirubin is insoluble in water, and also it does not get excreted in urine. So it gets accumulated inside the blood and results in jaundice condition. Okay, so in this case, the LFT will be normal, all the function of liver will be normal, the urobilinogen will be normal. So all things will be normal, but there will be accumulation of unconjugated bilirubin inside will be elevated. Okay, now second we have hepatic or hepatocellular. Okay, so as the name suggests, hepatic. Hepatic means liver and hepatocellular means cells of the liver, right? So this type of jaundice occurs whenever there is damage to hepatic cells. As the name refers, damage to hepatic cells, and because of the damage, the conjugation of the bilirubin get decreased. Okay, so as we know, the site of the conjugation of the bilirubin is liver. So here there will be decrease in the conjugation of bilirubin, right? So because of the damage, the conjugation of bilirubin in liver get decreased and liver fails to excrete bilirubin. So here liver fails to excrete bilirubin. So in this case, what will happen? Both unconjugated as well as conjugated bilirubin level get decreased. Both will be affected. Conjugated as well as unconjugated bilirubin get affected. And the causes here are in case of infection of the liver, in case of cirrhosis, in case of exposure to toxic material. Okay, so these are the all causes of hepatic jaundice. Okay, now the last we have post-hepatic or obstructive jaundice. Okay, so as the name refers, post-hepatic. Post-hepatic means after liver, and obstructive means there is a kind of obstruction present, right? So this type of jaundice occurs due to obstruction of the bile duct, and that obstruction could be due to presence of tumor, presence of stone, or if any kind of inflammation present in bile duct. Right? So this type of jaundice occurs because of the obstruction of bile flow, right? Due to obstruction of the bile flow at any level, and the bile cannot be excreted into small intestine. So there will be failure of excretion of bile to small intestine. So bile salts and bile pigment entered into the circulation, and the blood contains more amount of conjugated bilirubin. So in this case, there will be elevation in the conjugated bilirubin. And in this case also, the liver function test can be mildly affected, right? So what will happen? There will be obstruction to bile flow due to presence of tumor, stone, or inflammation in bile duct, and there will be failure of excretion of bile to small intestine. That's why there will be accumulation of bilirubin inside the blood, and there will be increase in the conjugated bilirubin. Why there will be increase? Because this occurs due to presence of stone or any kind of tumor in this duct. So means the bilirubin has already come out of liver. So all the bilirubin get conjugated. So that's why here only conjugated bilirubin get excreted. Okay. So this is all about the types of bilirubin. the types of jaundice. Now we're going to learn some difference between different type of jaundice. So we have prehepatic, hepatic, post-hepatic jaundice. And we're going to learn the difference. Okay, so first we're going to learn causes. So as we have seen in prehepatic, the cause due to excess breakdown of RBC. In second, in hepatic jaundice, the cause due to presence of infection in liver, or whenever there is any kind of damage present inside liver. Right? Then third, we have post-hepatic. In post-hepatic jaundice, the cause will be due to presence of obstruction to bile duct. Right? Now, what will happen to blood examination? So, in case of prehepatic, in blood examination, if there will be excessive destruction of RBC, so means there will be decrease in count of RBC. So it leads to condition like anemia and reticulocytosis. Otherwise, in hepatic, the blood examination will be normal. And in post-hepatic, the blood examination will be normal. Then third, we have Van-der-Burg test. Okay. So Van-der-Burg test is basically for the detection of bilirubin. So here it will show indirect positive reaction. In hepatic, it will show biphasic, because in hepatic, there will be decrease of both the conjugated as well as unconjugated bilirubin. So it will show biphasic. And in post-hepatic, only conjugated bilirubin will be affected. So it will be direct positive reaction. Okay. Then next we have urobilinogen. So as we know, in case of prehepatic, this urobilinogen will not be excreted because unconjugated bilirubin is not water soluble. So in this case, it will be absent. Okay. And in hepatic as well as in post-hepatic, both the case, because in hepatic, conjugated bilirubin is present, and in post-hepatic, conjugated bilirubin is present. So the urobilinogen will be present. Okay. Then next we have fecal stercobilinogen. So it will be increased in case of prehepatic because of increased formation of because there is higher than normal quantity of conjugated bilirubin is delivered due to intestine producing dark brown colored stools, right? And in case of hepatic, it will get reduced because conjugated bilirubin excreted in bile as reduced, causing pale feces. So there will be appearance of pale feces here, and in post-hepatic, it will be absent, producing clay-colored feces. Okay, so this is all about the major differences between prehepatic, hepatic, and post-hepatic. Okay, now we're going to learn about the sign and symptoms of jaundice. So as we have seen, the first sign and the symptom of the person who has become jaundice, that will be yellow discoloration of the skin, of the mucous membrane, the whites of the eye, light colored stool, dark colored urine, and itching of the skin will be there. Then the common signs will be the person will have nausea, vomiting, abdominal pain, fever, weakness, loss of appetite, headache, confusion, swelling of the legs and abdomen. Then finally, the types, whatever we have discussed, that in prehepatic jaundice arising from the liver before it, from the blood before it enter the liver, and total serum total bilirubin level is 0.3 to 1.0 mg per deciliter. And in intrahepatic, or we call it hepatocellular, so it will be due to disease of liver parenchyma. Liver parenchyma means tissue of the parenchyma of the liver whenever it get affected. And again, the serum total bilirubin level is 0.3 to 20 mg per deciliter. Then post-hepatic jaundice occurs whenever there is obstruction to biliary tree outside the liver. And again, the total serum bilirubin level is 0.6 to 45 mg per deciliter. Okay, so this is all about the prehepatic, hepatic, and post-hepatic. Then in prehepatic pathology occurs prior to the liver. Any cause of increased hemolysis, that is in case of spherocytosis, thalassemia, sickle cell anemia, transfusion reaction, and if the person is having autoimmune disease, malaria, and due to some presence of some kind of drugs inside blood. So these all are the cause of prehepatic jaundice, and there will be elevation in the unconjugated bilirubin. Then in intrahepatic jaundice, pathology occurs within the liver. All the causes of hepatitis and cirrhosis. Hepatitis is a condition in which there will be inflammation of the liver or liver cells. Cirrhosis, alcohol, viral autoimmune disease, primary biliary cirrhosis, hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, etc. Inherited condition on previous slide, and some drugs. Then neonatal jaundice occur in most newborns, and hepatic machinery for conjugation and excretion of bilirubin not fully mature until 2 weeks. So this is the cause of neonatal jaundice also. Okay, neonatal jaundice means that occurs in newborn babies. And why in newborn babies it occurs? Because the level of hemoglobin as well as the RBC count is more in the newborns, right? So after 3 days of the life, this RBC start destructed. So there will be excess elevation of hemoglobin, and it leads to excess formation of bilirubin, right? And because hepatic machinery for conjugation and excretion of bilirubin not fully mature until 2 weeks of age, that's why this neonatal jaundice is very, very common. Okay, now the third we have post-hepatic pathology occurring after conjugation of bilirubin within the week. That is called as obstructive jaundice, and any cause of biliary obstruction, for example, presence of gallstone, and there will be increase in the conjugated bilirubin inside the blood. Now, what happened? As we have already seen, whenever the lifespan of RBC get over, after 20 days, the RBC become fragile, the membrane become fragile, and it get ruptured, right? So, phagocytes by reticuloendothelial cells, which are responsible for the destruction of RBC, by tissue macrophages, Kupffer cells, which are present in liver and spleen. So, what will happen? The hemoglobin get ejected out of the liver, and hemoglobin gets split as heme and globin, where the globin will enter into amino acid pool cycle for reuse, and the heme, in which the iron part is there and the remaining part is there, right? So iron get converted into ferritin and stored inside liver for reuse again. And this remaining part, what will happen? This remaining part, so this remaining part, the straight chain of 4 pyrrole nuclei get oxidized with the help of an enzyme known as heme oxygenase, and converted into biliverdin. That get reduction will be there with the help of biliverdin reductase, and there will be formation of free bilirubin, right? Now there will be combination with plasma albumin. This free bilirubin that is unconjugated till now get entered inside liver. So in liver, what will happen? Within few hours, there will be absorption of this free bilirubin in the hepatic cell membrane, and there will be release from albumin. The albumin get unbounded from this free bilirubin, and the conjugation will start. Once the this free bilirubin get conjugated, so what will happen? It will get excreted. The excretion will start from the hepatic cells through the active transport that we have already seen, and the transportation to intestine will get start, okay, through bile duct, or we also call it bile caniculi, right? Now, conjugated bilirubin in intestine will also act with the help of some bacteria, and there will be formation of stercobilinogen, which get excreted with feces, and some amount of bilirubin gets excreted and enters into kidney, where it forms a urobilinogen, which also get excreted with urine. Okay, so this is all about the bilirubin, the RBCs, and about hemoglobin. Okay, now all the student have a question that which of the following is most closely associated with bilirubin, and you have 10 seconds to answer, and I know all the student knows the answer. The option we have: red blood cells, T cells, lymphocytes, and B cells. Yes, the answer is red blood cells. So as we know, the total serum bilirubin is 0.2 to 0.1 mg per deciliter. Conjugated is 0.1 to 0.4 mg per deciliter, and unconjugated is 0.2 to 0.7 mg per deciliter. Then, talking about the etiology, we know that the mechanism which is involved in a prehepatic jaundice is increase in heme liberation, and whenever there is defect in liver metabolism. So, the cause is only increase in heme liberation, and defective liver metabolism is the cause of intrahepatic jaundice. So, the causes will be hemolytic anemia, malaria, and reduced red cell lifespan. And in intrahepatic jaundice, the mechanism involved whenever there is any kind of defect present inside liver metabolism due to several causes like congenital enzyme defects, if there is defect in iron storage disease, reduced hepatic bilirubin uptake, and other are also there in post-hepatic. First, we have obstruction of small bile duct, or second, the obstruction of large bile duct. So, obstruction of small bile duct, the causes could be due to alcoholic cirrhosis, autoimmune liver disease, drugs and environmental chemicals, hepatic tumor, pregnancy, viral or other infection, gallstone, primary biliary cirrhosis. And obstruction of large bile duct, we have several causes like infection or inflammation of biliary tree, gallstone, carcinoma of pancreas, gallbladder, bile duct, pancreatitis, or in case of presence of any drugs. Okay, so talking about the pathophysiology, we know whenever there is any kind of condition arise in the body like hepatitis, means inflammation of liver, or if any kind of liver carcinoma, hepatic carcinoma is present. So first, what will happen in case of hepatitis and in hepatic carcinoma, there will be affect will present firstly in the liver cell. So there will be damage of the hepatocytes, and in whenever there is damage of the hepatocytes, so there will be it will leads to the hepatocellular jaundice or hepatic jaundice, and it will leads to increase in bilirubin, unconjugated bilirubin inside blood, and leads to jaundice. Then whenever cases like cirrhosis of liver, hepatitis, cholangitis, pancreatic carcinoma will occur. So they will all lead to obstruction of the bile duct, small bile duct, whether it is small bile duct or large bile duct, and there will be swelling, fibrosis, or obstruction of liver caniculi will be there, and it leads to post-hepatic jaundice, and there will be increase in the level of conjugated bilirubin inside blood. And whenever there is a disease like sickle cell crisis, blood transfusion, hemolytic drugs, hemolytic anemia, so what will happen? New excess hemolysis of RBC will be there. More and more RBC will start destruction, and it leads to prehepatic jaundice or hemolytic jaundice, and there will be increase in unconjugated bilirubin inside blood. So all are the reasons, all are these causes which are responsible for this condition that is known as jaundice. Okay, now diagnosis tests are there. So as we have seen in prehepatic, the total bilirubin will be normal or it can be increased. But in hepatic jaundice and post-hepatic jaundice, it will be increased always. The conjugated will be normal in case of prehepatic, and the reason we know already. And in hepatic and in both post-hepatic, it will be increased. Then unconjugated, it will be increased always. And in case of hepatic, it will be increased. And in case of post-hepatic, because all the bilirubin get conjugated, so that's why in post-hepatic it will be normal. And in case of urobilinogen, in prehepatic it will be normal, and some cases it can be increased. But in hepatic it will be increased, and in post-hepatic it will be decreased. Then in urine color, in prehepatic it will be normal, and in hepatic it will be dark, indicating the presence of hepatic jaundice, and in post-hepatic also it will be dark. Then stool color will be normal here. In hepatic, it will be pale, and in post-hepatic also it will be pale. Then all are these the liver function test, the liver enzyme. So it will be normal for prehepatic, and it will be increased in case of both hepatic as well as in post-hepatic, right? Then conjugated bilirubin in urine is not present because unconjugated is always water insoluble. That's why it cannot be appear in urine. And in case of hepatic and post-hepatic, this conjugated bilirubin will be present in hepatic and post-hepatic jaundice. Then splenomegaly. Splenomegaly means enlargement of spleen. So obviously, if the more number of RBC getting destructed, so there will be over-functioning of this spleen, and there will be enlargement of spleen. So it will be present in prehepatic, and it can be present in post-hepatic also, but it will be present in hepatic jaundice, but it will be absent in post-hepatic because this post-hepatic is totally depend upon the obstruction. So there is no involvement of spleen in case of post-hepatic. So splenomegaly is always absent in post-hepatic jaundice. Okay. Then as we have seen, urine bilirubin is negative in case of prehepatic, negative in case of hepatic, but sometimes it appears, and there will be increase in post-hepatic. Urobilinogen increase in prehepatic, normal in hepatic, and decrease or negative. Then urine color is normal. Here it will be dark, and also it will be dark. And the stool color will be normal in prehepatic, but it will be pale color. It will be, just give me a minute. The stool color will be normal for prehepatic, and for hepatic it will be normal, and for post-hepatic it will be pale color. And in case of hepatic also, it is sometime pale, right? So this is all about the etiology of jaundice. So what are the investigation are there for prehepatic jaundice, hepatic jaundice, and post-hepatic? So following investigation will help to determine the nature of jaundice, like liver function test, in which we test for level of bilirubin, various enzymes like ALT, ALP, and also we test for the level of conjugated and unconjugated bilirubin level. And also for post-hepatic jaundice, to find out the case of obstruction, so sometime ultrasounds are also needed. Okay. So this is also the investigation that is for post-hepatic jaundice. So talking about the total bilirubin, conjugated bilirubin, and unconjugated, that already we have discussed. So for prehepatic, this will be mildly increased, the conjugated will be normal, and the unconjugated will be increased. For hepatic, all will be increased, and also for post-hepatic, total and conjugated will be increased, and the unconjugated will be normal. So liver enzyme, ALT and AST mainly present in hepatocytes, ALP and GGT mainly present in bile, canaliculi, biliary tree. So dearrangement of particular liver enzyme in association with jaundice can determine nature of the jaundice. So as we can see, in case of prehepatic, the level of all these liver enzymes will be normal. And in case of hepatic, the ALT will be increase and slight increase in ALP, whereas in post-hepatic, slight increase in ALT, whereas ALP will be severely increased. So all these things already we have discussed. Then what can be the prevention of the jaundice? So due to wide range of potential causes, it's not possible to prevent all case of jaundice. There are more four main precautions that can take to minimize the risk of developing jaundice. So that are ensuring that the person should stick to the recommendation daily amount of alcohol consumption to maintain a healthy weight for height and build, if appropriate, ensuring that the person should be vaccinated against hepatitis A or B infection, and vaccination would usually be recommended depending on where in the world the person is traveling, and also minimize the risk of exposure to hepatitis C because there is currently no vaccine available for hepatitis C. Okay, so these are the preventions. Okay, then MCQ we have presented with a bunch of test results back showing the condition of bilirubinemia, increase in the level of bilirubin in the case of patient that is also have jaundice because of the which of the following is least likely to be the cause. So the option we have these. Yes, the answer is hemolytic anemia. Because all are the causes of jaundice, except the hemolytic anemia is also a cause, but the least they are asking, so least will be hemolytic anemia. So thank you for watching. And also we have a clinical case scenario. So they are asking that upon examination, there is mild hepatomegaly, increase in the level of total bilirubin and direct bilirubin. So it is indicating what? And also the dark color urine is observed. So means prehepatic is not present. Then what the condition is present? Yes. So the answer is B, presence of conjugated bilirubin in the urine. The B will be answered. So I hope all the students find this class more useful. So thank you so much for watching this session.